Hello, students, and welcome to Psychopathology and Diagnosis. This is going to be our very first lecture, and to be successful in this class, it's going to be very important that we approach the material that we review for these various different diagnoses with a mindset rooted in empathy and a focus on truly seeing the individual and reflecting on what we've discussed in our class, really understanding and connecting with the person who's in front of you and not just seeing them as a diagnosis. So we want to strive to recognize all the factors that contribute to who the person is and enabling you to make a diagnosis that's going to be grounded in evidence-based practices. So this semester we are going to be using the DSM-5. We are now on the 5TR, and this is going to be our primary resource. Each week we're going to explore different classifications of disorders assigned from the readings in the DSM, and that's going to guide our discussions. The DSM-5 replaced the DSM-4 in 2013, which focuses on clinical research and education. It's grounded in empirical evidence, and it's widely used by psychiatrists, psychologists, counselors, and medical doctors across various different settings. It was developed by 13 dedicated working groups, and the DSM reflects extensive collaboration and research. As we delve into this text, let's remember the importance of understanding the historical context. In our introduction to mental disorders, we emphasize the value of knowing where we've been to chart and navigate to where we're going. Consider experiments like the Rosenhand and other foundational studies that we've explored as we analyze the evolution of mental health diagnoses and the framework. So the development of the DSM has deep historical roots, as humans have always tried to name and classify phenomenon. For over 2,000 millennia, we've named various conditions, and as evidenced by historical discussions for things such as syphilis, these names often reflect the prevalent perspectives of that particular time, and whether they're tied to medicine or the medical model or the biopsychosocial model, or even religious or cultural interpretations. Historically, we've aimed to classify disorders to better understand and study them. Over the years, different systems have emerged to categorize mental disorders, driven by the need to explore the research these conditions. The first official attempt occurred in 1840 during the US Census, which included just one category addressing mental health conditions, and by the 1880s, it had expanded to 7 categories. However, these classifications were still very vague, limited in scientific understanding at the time, and relatively narrow despite a further appetite to really explore and check this out further. So, like the DSM, its predecessor started with the DSM-2, and it organizes diagnoses into subtypes and specifiers to provide greater clarity and precision. So, a subtype, as defined by the DSM-5, are mutually exclusive and jointly exhaustive phenomenological subgroupings. This means that within the category of a particular diagnosis, so say for example, bipolar disorder or autism spectrum disorder or ADHD or depression, there are distinct subtypes that an individual can only meet one criteria of a subtype for within that diagnosis. And then there are specifiers, on the other hand, that differ from subtypes that are not mutually exclusive and they're not jointly exhaustive. Instead, specifiers allow for additional detail, helping to create a more homogeneous subgrouping or describe particular features that may or may not be present in an individual's presentation. So this distinction between subtypes and specifiers is something that we'll delve into further as we examine each classification of disorders throughout this course. So we're going to start looking at the history and more in depth. We're going to start with the DSM-1 and move all the way to our current edition. The DSM-1 is the first edition of the modern diagnostic manual that we use today. It was published in the 1950s, and its primary focus was on clinical utility, providing a standardized language and classification system to aid in developing evidence-based treatments. This edition was heavily influenced by Adolf Myers. That was his his psychobiological view, and that really emphasized reactions. And he was really observing reactions and symptoms. And as a result, the DSM 1 was highly symptom focused and did not account for cultural context, reflecting a lot of the limitations at the time. And the DSM 2 followed, but it introduced very minimal changes. And the most significant shift came from the publication into the DSM 3, which came out in the 1980s, which marked a major evolution in the diagnostic practice and classification. So the innovations that transformed the DSM from its initial version through subsequent editions, culminating in the significant changes in the DSM-3, were very substantial. So one key advancement was the introduction of explicit diagnostic criteria. It shifted the focus from simply observing symptoms to systematically determining whether a person met specific criteria, such as criteria A through F or A through D, for diagnosis. It required clear and structured evaluation to confirm the presence of necessary symptoms. The DSM-3 also introduced the multi-axis system, which categorized disorders into different axes in a more comprehensive diagnostic framework. So, for example, Axis 1 included disorders considered more treatable, while Axis 2 covered more pervasive conditions, uh, namely personality disorders. And additionally, the DSM 3 provided a detailed descriptive narrative of the disorders, outlining specific symptoms and diagnostic guidelines. These changes laid the foundation for the format that we see in today's DSM, which continues to include diagnostic criteria alongside some very thorough discussions of each disorder and their groupings. So the DSM has undergone some very significant transformations since the first edition that came out in 1952. The DSM-3 was published in 1980. Again, it introduced some major innovations, including explicit diagnostic criteria, the multi-axial system, and enhancing the manual's clinical utility. Now here we've got the DSM-4. It came out in 1994, and it further redefined this criteria, emphasizing empirical support for diagnoses and aligning with international standards like the ICD-10. It introduced the NOS, not otherwise specified category, allowing clinicians to account for atypical presentations that didn't fit specific criteria. In 2013, the DSM-5 was published, marking a shift towards a more dimensional approach to diagnosis, and notably, it eliminated the multi-axial system and restructured various disorder classifications to reflect advancements in psychiatric research. Although the additions of the DSM have evolved to incorporate a more nuanced understanding of mental health, there's a strive to balance the clinical utility with the complexities of human behavior, and each revised edition reflects ongoing efforts to improve diagnostic accuracy, treatment outcomes in the field of mental health. So, the development of new revisions such as the DSM-4 aim to address factual errors and inaccuracies and ensure inclusion of up-to-date information, reflect emerging findings in the field. For example, the DSM-4 literature reviews were finalized in 92 and created a foundation for a more accurate and comprehensive diagnostic manual. However, the DSM-5 emerged in 2013. It was clear that there were significant updates that were necessary to keep pace with the advancement in science and clinical practice. There was a long gap between the publication of DSM-4 and 5, which highlighted the need for interim up-to-date due to rapid developments in our understanding of mental health. So, for instance, imaging technologies and neuroscience breakthroughs in the late 1990s and early 2000s significantly advanced our knowledge of these disorders like anxiety and depression and bipolar disorder. And these findings have made it essential for the DSM to continue to evolve and incorporate the latest research. Now, while the DSM-4 remained applicable for many years, ongoing revisions were vital to enhance its educational value and maintain its relevance. Review boards continuously evaluate emerging evidence, ensuring that the manual stays aligned with advancements in psychiatry and neuroscience, particularly for our understanding of the brain and the mental health disorders continue to deepen over time. After all, human behavior is incredibly complex and ever-changing, and necessitating the need for regular updates to reflect the dynamic nature of the field. So the transition from 4 to 5 brought about a clearer definition of what constitutes as a mental disorder. For the purpose of this course and our work in the DSM-5, we define a mental health disorder as a clinically significant behavioral or psychological syndrome or a pattern that is associated with distress or disability. Additionally, it must significantly increase the risk of suffering, death, pain, disability, or an important loss of freedom. In other words, there must be an observable impairment. As discussed in other courses, if there's no impairment, then it doesn't meet the criteria for a disorder. This distinction is crucial when evaluating individuals from a clinical perspective. It's important to remember that classifying a disorder does not equate to classifying a person. We do not label individuals by their diagnoses. For example, we do not say that someone is a borderline or a schizophrenic. Such language is unprofessional, but it's also dehumanizing. Instead, that we use person first language and that we say that an individual struggles with or has been diagnosed with a particular disorder. So this approach respects the individual and acknowledges the complexities of their experience. Additionally, cultural context plays a significant role in diagnosis classification. Terminology and understanding of disorders can vary across different parts of the world, and recognizing and respecting these differences is a vital part of improving and providing cultural competent care and avoiding stereotypes in our practice. The DSM-4 and 5 are not without their flaws. They were created by humans, and humans are inherently fallible. One of the key limitations lies in the categorical classification system itself. Mental health is complex and constantly evolving, so we must ask, are these categories truly accurate, or are they grouped in ways that make sense? And it's important to note that these categories are not entirely discrete entities. Mental disorders often overlap and bleed into one another, if you will, and individuals share the same diagnosis may exhibit vastly different presentations. In other words, people have the same diagnosis, but they are very, very different in the way in which they present because human behavior and experiences are inherently different and diverse. Another challenge comes from the polythetic criteria used in the DSM. We'll talk about this more in our personality lecture. This means that individuals only need a subset of the listed criteria, not all of them, to receive the diagnosis. This raises important questions about how do we reconcile someone only meeting a few criteria compared to someone who meets all of them. What does this mean for the diagnosis and for the treatment? These are the kind of issues that we're going to explore further as we discuss the diagnostic continuums throughout the semester. Additionally, the DSM-4 incorporated the Global Assessment Functioning, GAF score, to offer a more holistic view of the client. However, the DSM-5 eliminated this system in favor of a purely diagnostic approach, which focuses on specific criteria rather than a comprehensive assessment of overall functioning. This change reflects a shift in how clinicians apply the manual, but it also underscores the importance of using clinical judgment in conjunction with the DSM. A small but notable difference between the two editions is their formatting. The DSM-4 used Roman numerals, while the DSM-5 uses Arabic numerals, and this was an intentional update, not a misprint. Ultimately, while the DSM provides a common language for mental health diagnosis, it's far from perfect. It reflects the consensus of experts at the time of publication, but it remains a work in progress. New disorders will be identified, and some existing ones may be revised or removed in the future editions. And this is why your clinical judgment is going to be absolutely crucial. Proper training and experience are essential for applying the criteria flexibly and effectively. As clinicians, we need to stay informed and competent and compassionate, always adapting our approach to meet the needs of the individuals that we serve. Clinical judgment requires us to consider cultural factors, which is a crucial aspect in our work. Culture and religious practices or beliefs can sometimes be misinterpreted as psychotic disorders. For example, someone entering a prayer state or experiencing hallucinations after fasting, sensory deprivation, or giving may be misunderstood without considering the cultural context. So this underscores the importance of a comprehensive evaluation where the initial diagnostic assessment is only the first step. We must look beyond the symptoms and ask, what else should we be considering? Who is the person sitting in front of us? It's essential to remember that we treat the individual and not the diagnosis. So throughout this semester, keep this in mind. We treat the people and not the labels. As we dive into the neurocognitive and neurodevelopmental disorders, I encourage you to connect with the human lived experience within the diagnostic criteria that we're going to explore. Look at all the things in our module, engage with the material, and remember that behind every diagnosis is a person with a unique experience and context. Oh, we're one slide behind, I apologize. As we work through this first module, take time to really familiarize yourself with how the book is organized. Each week, we're going to be exploring different groups of disorders, and we may move around a bit because many of them share common neurological factors or treatment approaches, and that can help in the understanding of them. So you'll notice that certain disorders tend to occur with one another. So we're going to wrap it up here. Thank you for your time and attention, and I'll see you in the next one.